I must explain to you, as I have to, I suppose, each year that I've been coming, that I don't really belong here. I am not an expert in leprosy control. I'm not an epidemiologist. I'm not a bacteriologist. Or really am I concerned with the pharmacology of the disease. But having worked with it for many, many years, I suppose nearly 40 years, I have gotten to know it pretty well. And my object here this morning, in part, is to talk about my own angle on the disease, on Hansen's disease, on the disease of leprosy, which is the rehabilitation problem. How to get a person who has had leprosy back to normal life again, back to reintegration in society. That's my business. That's, in that area, I can perhaps claim to be something of an expert. But at the same time, I'm glad to have the opportunity of talking with people whose primary work is likely to be in control and perhaps in epidemiology, who'll be working with public health. Because so often I find, particularly in countries where funds and resources are limited, so often one finds that the authorities, health authorities, government authorities, fiscal authorities, have to give, or feel that they have to give, a priority to public health, and to feel that their responsibility, or your responsibility, is to diminish the number of cases and the number of bacteria, bacilli, in the country, even though you can't afford to spend time treating individual patients. There's a kind of competitiveness in many countries. I'm not really criticizing this because I know with limitations one's got to give priorities, and there's a sense in which people feel that you're working in public health for the next generation. I remember Dr. Gordon in Harvard once said to me about leprosy that he thought you had to write off the present generation. If they were deformed, well, that's too bad. If they were blind, well, you couldn't help that. You write off the present generation because you're trying to eradicate the disease for the next generation. And it is that philosophy that I think needs to be more carefully examined. And I believe that Hansen's disease, or leprosy, gives us a good opportunity to put these two concepts side by side and see the relationship of personal individual medical care, the doctor-patient relationship, how that affects the more statistical approach, where you're concerned with numbers and prevalence and incidence and all the other things that epidemiologists and public health people have to be concerned with, and whether indeed it is appropriate to regard them as being competitive with each other. And my conclusion is going to be that they really should not be thought of, at least in leprosy and perhaps in many other diseases, that they shouldn't be thought of as competitive, even for the available money, and that perhaps both will do better when we consider both of them together. So that there's a sense in which I've now finished my lecture. This is what here's the conclusion of it, and we can all go home. But seeing we brought a video taping team down here, I think we might as well look at it in a little bit more detail. And before I show you any slides of rehabilitation, which is my real subject, I would like to say a few words about leprosy in general, in the very most superficial way, and this is probably just going over material that's already fully familiar to you. But let me just emphasize those aspects of it that have seemed important to me. It's a disease, as we know, that's caused by the Mycobacterium leprae, sometimes called Hansen's bacillus. It's rather strange that I believe it's true to say that Hansen in Bergen of Norway, was probably the first person to isolate, at least not to identify, a specific bacillus as being the cause of a specific disease. This was before Koch worked on tuberculosis and so forth. In 1873, well, in fact before that, but in 1872 or 3, he published his work on this. And yet, it is the last bacillus to resist cultivation. All other bacilli, all other cocci, have been subjected to culture. Tuberculosis held out for a long time until I don't know how we grew it, maybe on egg or something of this sort, but whatever it is, we can grow tuberculosis now, and therefore we can distinguish. It's one of the best ways to distinguish tuberculosis from leprosy, because the two bacteria look very, very much alike. If you look under a microscope, and if you're not too much of an expert, the Mycobacterium leprae and the Mycobacterium tuberculosis look very, very similar. They're both acid alcohol fast rods, and you can easily mistake one for the other. But you put them both into culture media, all culture media. Some of the culture will grow tuberculosis, but none of them will grow the Mycobacterium leprae. Another thing they have in common is that they're a little bit slow. Slow to develop, slow to multiply, slow to establish manifest disease, and slow to be healed, to be cured. Now, in this respect, Mycobacterium leprae is much worse than tuberculosis. It's so slow that in the majority of cases, it's at least 2 years, sometimes a lot longer than 2 years, between the time of the presumed infection and the time that the symptoms begin to show themselves. So that it's very difficult to track the etiology, the development of the disease in leprosy. It's very difficult if a person comes up with a patch of leprosy on his arm to say to him, well, now, what were you doing 2.5 years ago? Were you in contact with another case? And knowing it may not be only 2.5 years, it may have been 5 years ago that he made his contact, so that it's very, very difficult. And we still don't know. I'm the only person who admits we don't know. All leprosy experts will always tell you that they know how leprosy is spread. They all have different ideas, but they're all quite sure about them. But I don't know how leprosy is transmitted from one person to another. In fact, maybe I'm the only person who does know. You know, people talk about, they used to talk about skin-to-skin contact, but that seems to be out now. But people talk about coughing and sneezing, because leprosy gets into the lining of the nose, and when you sneeze and you hold a plate in front of your nose or your mouth, the droplets expelled from the nose in a case of multibacillary leprosy will show a lot of mycobacteria. And therefore, it may be said that that is a probable way of transmission. But it isn't anything like as simple as that. And I know that because England, the United Kingdom, has something of the order of 600 leprosy patients, none of whom, or almost none of whom, are in hospital. They are free to move around and they're free to take treatment, and no one is going to shoot them if they don't take treatment. So many of them are untreated at any given time. And Britain has more sneezing going on per capita than anywhere else in the world. It's a kind of a constant sneeze if you live in Britain. And yet, for the past 40 or more years, there has been no recorded secondary case of leprosy which has occurred in the United Kingdom. All the cases in the United Kingdom have been contracted overseas. And there was something going on overseas which is not going on in general in Britain. And it seems as if you just can't catch the disease in Great Britain in spite of all the sneezing that's happening. So this is all nonsense, even though very dignified and high-titled epidemiologists talk about it, it just cannot possibly be true. There has to be something significant else. And then you get a country like Norway, which was very, very prevalent, had a lot of leprosy in the say 600, 700 years ago, and more still, I think, in 100 years or so later. And Iceland and parts of Britain and northern Germany. It was a very prevalent disease. And yet, as the standard of living rose, we don't know what the factor was, better nutrition, better clothing, better homes, better plumbing, better hygiene, something. The disease died out long before there was any treatment available. It just didn't spread anymore. People hadn't stopped sneezing, but there was some factor missing. And today, we're very interested in the armadillo. I don't think anybody's very seriously said the armadillo is a way of spreading leprosy. But it has been shown that the armadillo, the 10% of all the wild armadillos in Louisiana, Texas, and Florida, have leprosy, have active leprosy. It's the same bacterium, the same mycobacterium. And why should the armadillo, of all animals, it's the only animal that does it naturally in the wild, why should it be so susceptible to this disease? And now the soil is full of mycobacteria. And we know that there are dozens of mycobacteria in the soil. Most of them aren't pathogenic. If the disease were picked up from the soil rather than from a person, it might suggest that an animal who lives burrowing in the soil all the time might be very subject to the disease. And it might suggest also that people who were so poor that they slept on the bare earth rather than in structured houses with carpets and wearing shoes, people like that might be more likely to get leprosy than people who wear shoes and clothes and sleep in houses that have floors to them and beds and so forth. And this would fit the epidemiological picture in many ways very well, because you might, I'm not going to go into detail here, but all I'm really saying is we don't know how it's spread, but we do know that in certain parts of the world it tends to continue to be prevalent even when fairly effective methods of treatment are applied. And this is one of the reasons why it's a little difficult to control the disease, because you may treat every patient in a certain area, and yet, even though you've had a very great impact on the immediate prevalence of the disease by treatment, nevertheless the incidence tends to keep up. And those new patients who come with fresh disease have gotten it from somewhere. So let's be honest and say that we really don't know. But it does spread, and it spreads more within families and within homes. The other thing to remember, which you probably know, is that something like 95% of all the human race is immune to leprosy. That anybody who has an absolutely normal immune system does not contract leprosy, no matter how he lives or where he lives or what his contacts are. That the mycobacterium is destroyed after entry in the body in people who have a normal immune system. But something like 5%, 4%, 6% in various different races and countries where the immune system has a specific defect. We don't exactly know what the defect is. It may be in the T cells, in the T cell lymphocytes, but if there is an immune defect, then those people are susceptible to leprosy, and they can get it perhaps rather easily. It used to be said that leprosy was contracted mainly in childhood. And certainly in the days when I was young, the studies that were coming out of the Philippines and out of India and places like this showed that the vast majority of new cases were always in children. And therefore the official, if you look at the old textbooks, they say leprosy is a disease contracted in childhood and that older people are relatively immune. Well, that's another lie. The reason that leprosy is in the Philippines and in India, which is where the studies were done, the reason why most of the new cases are in children is that it's a very widespread disease in both those countries. And where I used to live in India, in South India, the prevalence of leprosy was something of the order of between 2 and 3% of the whole population. 25 and 30 cases per 1,000 was not uncommon in my part of the world. But now, when you've got that number of cases of leprosy, every child comes into contact with leprosy. You can't help it. If 3 people in every 100 people in the street have leprosy, then every child who bumps into individuals wherever they are is exposed to leprosy. Now you see, if they are susceptible to the disease in those areas, they will get it. If they're not susceptible, they will survive childhood without getting it, and now they are non-susceptible adults. And all the adults either have leprosy or are not susceptible to it. Now that's an exaggeration, but you see what I mean. And therefore the reason adults didn't get leprosy was that they're not susceptible. If they had been susceptible, in that environment of high endemicity, they would have gotten it when they were children. Now you see, you go to a country where there is not a high endemicity, and this is true of some of the countries that used to be highly endemic. There, the chances of a child meeting an infected person and contracting the disease is small. And therefore, even if a child is susceptible, it will survive into adult life without getting the disease. Now, if you expose that child as an adult to the disease for the first time, they are just as susceptible as they would have been if they'd been exposed as a child. And therefore, the smaller the number of patients in any population, as for example in the United States, the smaller the number of patients there are, the older is the average age of incidence. And it's one of the ways in which you can tell whether leprosy is dying out or not. You can find the average age of new cases. Now in the United States, the average age of cases which come up with leprosy caught within this country is becoming very, very high. Children don't get the disease in this country, or very, very rarely. The average, I don't know the figures, but they're quite elderly people. And finally we'll get to the point where nobody gets it at all, we kind of hope. Well, so much then for that aspect of the disease. Now, let's think for a moment about the effect of the disease, because this is where rehabilitation comes in. If there's one disease in the world which 40 years ago might have been said to be beyond rehabilitation, it would have been leprosy. Still is, perhaps, in the eyes of many people, because the very word leper, which is so often used about leprosy patients, it means an outcast. You know, you talk about a moral leper, at least people do sometimes in this country, meaning that morally they are outside the acceptability of social life. And so the very idea of having leprosy and returning into normal life was unthinkable at one time because of the high stigma. And I have often asked myself, in some puzzlement, why? Why should leprosy be unique in respect of the fear with which people think about it and the horror at the thought of getting it themselves, the extent to which they will shun and throw out of their local village or their local use of the well anybody who has the disease because they're so afraid of its being transmitted. It isn't just the transmissibility, which we've just seen is not very high in the total population. It isn't that it's a terribly killing disease. You know, I'd far rather have leprosy than most forms of cancer. But cancer doesn't arouse the same horror and fear and stigma that leprosy does. And tuberculosis is a much worse disease than leprosy, and it attacks the vital organs. It may destroy the lungs, it may even get into the brain and form a tuberculoma, and all sorts of things with tuberculosis, bones and joints and crippling conditions like that. Leprosy is nothing like as bad as that. The germ is a quiet, gentle, rather friendly little animal, really. And it proliferates in the skin. It's a disease of the superficial tissues of the body. We'll look into the reason for that. But by and large, the deep organs of the body are really minimally affected, and the brain is never affected, and the lungs are never affected, and the heart is never affected, and the intestines really get by very well. So that a person can live a pretty good life, have good digestion, and enjoy life, and study, and do many, many things, and only the surface of the body, the eyes, of course, it's very bad. It may cause blindness, it always causes ugliness in some respect, and then it causes superficial paralysis and loss of sensation. They lose pain sensation. Now, why should all that lead to the gross stigma? And what has that got to do with leprosy control and certain other things? Well, now, the bad things, the things that make leprosy a barrier, that make it a barrier to rehabilitation, I suppose you could say one of them is the way that people look. Appearance. Now, it shouldn't be so, but it is true that ugliness or any departure from the cultural norm of beauty, whatever that may be in any given country, any departure from that is a disadvantage. You know, if you're applying for a job and you're much below the average of height, or much above the average of weight, or if your nose is much bigger or much smaller than people like it to be, you feel at a disadvantage. You can have the wrong color skin. You can be just wrong, you see, in your appearance. And this is a very common thing. We don't like it, but it's true. We all know it's true. And if a person is a burn patient, now I've done a lot of rehabilitation, and one of the hardest things to rehabilitate from is burns. It was a lot in India, but I've seen it much in this country. I had a case not too long ago here in Charity Hospital of a woman who had been burned with gasoline. And she was a handsome young woman with good prospects. And suddenly, with the flame having seared away all the tissues of her face, and when the burn healed, her mouth was drawn off to the side and her eyelids had been burned off, and she really looked horrible. It was just a massive scar. And to her, it was the end of her life. It was the end of her prospect for getting married. It was the end of her prospect for going, who can take a face like that and ask for a job? She's the same person, but surface ugliness is something which affects people, and it's very sad that it does. It affects their prospects for life. And as a plastic surgeon, I've sometimes worked to reconstruct faces like this and to see whether we can give them a better chance of a normal life. But leprosy isn't all that bad. Nothing like as bad as a burn patient. The actual ugliness itself disappears pretty much with medical treatment. Nodules on the face and so forth, they disappear. And yet, residual scars which identify the person as leprosy still are a barrier to re-employment. Another thing that could cause a disability in rehabilitation is paralysis. The superficial muscles of the hand and the superficial muscles of the foot and the muscles of the eyelids get paralyzed. And this results in a claw hand, and it makes it difficult for a person to get a job. But even so, there are plenty of jobs you can do with that minor kind of paralysis. Many clerical jobs are perfectly possible, but the patient still can't get them. And I have a feeling that the overwhelming problem in this disease is loss of sensation, and particularly loss of pain sensation. Because once a person has lost pain sensation, they look upon themselves as different. It isn't just that other people look at them, they look upon themselves. You know, our body image, you might think that your image of yourself is what you see. But it isn't. It isn't. In theory it is, but deep in your subconscious mind, your image of yourself is what you feel, is touch, and particularly pain. You've heard of phantom limb? A phantom limb is a condition in which a person loses their leg by an amputation or their arm. They lose their leg as a result perhaps of injury or diabetes or something. But if a person has had a grave injury and the foot has been smashed, then they go to a surgeon and the surgeon cuts it off and makes a neat-looking stump, and then you get an artificial limb and you walk on an artificial limb. Well, after the operation is all finished and it's all healed, that person sometimes lies in bed and calls the doctor and says, I can feel my foot. It's still there. And the surgeon says, no, it's not there. I cut it off. And he'll throw the bedclothes back, and the patient says, oh, it isn't there. Then he put the bedclothes back over him again, and he says, well, I can feel it. I'm wiggling my toes, the toes that aren't there. And sometimes the phantom limb will be painful, and he will feel agonizing pain in the heel of his foot or in the toes of his foot, the foot that isn't there. And that pain may be so severe, and that phantom, that ghost of his old leg, is so much present in his subconscious that it comes to dominate his life. And it isn't much use cutting the leg off higher up, because a new phantom starts. And I've known many cases of this, and it's very, very hard to get rid of. Now, why does a person get a phantom limb? He gets a phantom limb because the cut end of the nerves that used to supply the foot becomes surrounded by a neuroma. And that neuroma presses on the sensory nerves, and it sends impulses up to the brain. And if the brain receives impulses which are labeled as nerves of the foot, it records an image of the foot to fit them. And to that man, he has a foot, and it hurts. And if he were to be tranquilized with pentothal, if he were given a kind of dose enough to make him a little bit dreamy, and then you gave him a pencil and said, draw an image of yourself, he would draw a complete person, including his foot. Now, the disease of leprosy, and it also applies to diabetes, when that destroys the nerves of a foot, it doesn't cause a neuroma in the ordinary sense of the word, or the neuroma doesn't send sensory impulses up related to the part distal to the lesion. And therefore, a person with leprosy gradually, quietly loses sensation in his foot or in his hand, but it doesn't hurt him. He doesn't get paresthesias, he doesn't get pricking pins and needles, except perhaps very transiently. And if you pull the bedclothes up over his feet and you asked him, have you got a foot? He will say, no, I don't have a foot. And you pull the bedclothes over and he says, oh, yes, it is there, but I can't feel it. And if you tranquilized him and gave him a pencil and a piece of paper and said, draw an image of yourself, he would draw a head and a trunk and stumps of legs, not the whole foot. Because to him, the foot isn't there. You see, it's like a reverse phantom. Now, when you get that attitude to your own hands and feet, and it applies also to the eyes, which become insensitive, you no longer treat your limbs as if they were part of you. You treat them as if they were just things attached to you. People have called them to me, patients have said to me, sometimes I get very angry. I may not look an angry kind of person, but sometimes I have worked on leprosy patients, and I have exerted all my skill and spent a lot of time trying to reconstruct hands and feet that have been damaged by leprosy. And I transfer tendons and I move them around and I get the fingers moving again and I feel very happy. And I take photographs and I think, well, this is wonderful. And then that patient goes away and he does something absolutely crazy. He picks something out of the fire without bothering to use an instrument. He just puts his hand in and takes it out. He does something unspeakable. And I get angry with him because I see my beautiful work has been burned. Or he has a septic foot. He has an ulcer on his foot, like a diabetic gets. And I heal the ulcer with plaster casts and things of this sort, and I give him special shoes, and we make special shoes, and we check them for pressure, and we do everything, and he goes out with shoes that to me are beautiful. They're a little bit big, and sometimes when women see their shoes, they really have a shock. But never mind, they are good shoes. They are shoes which, if they wear them, they will not become, they won't damage their feet anymore. And then I meet these same people over whom we've taken so much care. You meet them in the street, and they've been to the store and they've purchased a pair of plastic shoes with high heels that squeeze the toes and that look very shiny and smart. And I look at those shoes and I get angry. And I say, why don't you take care? We've given you these shoes. They're made for you. They're good for you. They say, well, I'm going to a party. And I don't want to look as if I've got clodhoppers on. I want to look nice. And it's so important to them to look nice. And then sometimes they'll break down and they'll say, well, you know, to me, it isn't my foot. To me, it's just a block of wood to walk on. Why should I take special care of a block of wood? Now, I say, to me, this is the basis of stigma. Because not only does this person treat his feet and his hands and his eyes this way, but everybody who sees him observes it. and they see a person walking without a limp on a grossly septic foot. They see a person undertaking destructive behavior on his hands, or even scratching his eyes without the eyelids being closed. And these people say, these are dead tissues. And that's why people talk about fingers dropping off in leprosy, as if the flesh was non-healing and the limbs were just falling apart. It is living tissue, but to the patient it is dead, and he treats it as if it were dead. In some parts of India, anybody here from India? Yeah. In some parts of India there's a name for leprosy, which is the creeping death. People talk about it as the creeping death. And what they mean is not that the patient, the central part of the patient is dying, but he's dying from his fingertips upward and from his toes upward. And this gives, you know, if you think a person's dying little bit by little bit, you have a bad feeling and you withdraw from him. And I think that this is a stigmatizing thing. You don't want to get a disease like that, says the average person. Now, with all of these problems, the final impact upon the patient of the disease of leprosy is not measured by the number of bacteria that he has. He doesn't even know how many bacteria he has. He can't look down a microscope. To the doctor, he has a bacterial index of 5 or 6, and that means so many billion bacteria. But for himself, his disease is measured by stigma. His disease is measured by the extent of his rejection. And when you come to him with treatment and offer him treatment and say, this will cure the disease, what he is looking for is a return to his family. He's looking for a return to his job. He's looking for the hope of getting married again. All the things that he was hoping to do before he got the disease, now he suddenly says, well, if they can treat me, I'm going to get back. This is the important thing. The disease is dominated by stigma. Dominated. And if he takes your treatment and takes all the bacilli, takes all the tablets, and after a year or two you check his bacterial count and you say, you're getting much better. And he says, well, my hand's getting worse. I lost another finger last week. Or my eyesight is getting so dim that I can hardly see. And you say, well, just go on taking these tablets. And at the end of another year, you say, you're cured, you're finished. Disease is finished, there are no bacteria left, and here's a certificate. And you can take this certificate home with you, and you can show it to your employer, and you can show it to your family, and you can show it to your prospective bride, and they will know that you don't have leprosy anymore. And he turns around and looks in the mirror. Or he looks at his hands or at his feet. And now he has lost the front half of one of his feet. Perhaps his thumb is destroyed and his fingers are clawed. And they say, I'm not cured. And if you insist that he is cured, he thinks that you are a fool. And I think he's right. Because it means that you are judging a living person in terms of physical criteria to which he doesn't have access, and which, in the practical things of his life and of his scale of values, are irrelevant. Because what he has left as a residue of his disease is as bad to him, and it affects his life in the same way as when his disease was active and had living bacteria all over his body. Now, I just leave that with you now, because this is a background to leprosy control. And this is the reason, the overwhelming reason, why the majority of leprosy control programs in the world today have failed. Now, when we're through, I'm going to show you some slides now. When we're through with the slides, which take us into some specifics about the disease and about the way in which we can handle and prevent deformities and correct deformities, how we can help people to live a relatively normal life. When we've been through that, then I want to come back and complete this preliminary introduction that I've given you by telling you the history of leprosy control programs that I have been associated with in the World Health Organization, And so I view it sometimes from both sides. I am actually a member of the World Health Organization. I forgot to tell you that. I'm a member of the expert panel. So, you know, there I am. But I am one of the World Health Organization's most vocal critics, because by and large it's dominated by epidemiology and control, which neglects the human element. Now they're getting a little better. I sort of hope that some of the things I've said about them may have stimulated them. They are getting a little better. But still, this is true, and it isn't altogether their fault, because governments sometimes say, governments of African countries, governments of Asian countries, they say, well, we don't have enough money to correct deformities. We don't have enough money to be concerned over shoes. All we can afford is tablets, and therefore we'll concentrate on them. And maybe that's the best they can do. But just think about these things while we now look into the whole question of the pathology and the management of this disease. Now here is a typical case of lepromatous leprosy. When I use the word leproma, I'm referring to the multibacillary patient who has no resistance. When there is no resistance, this is a minority of cases worldwide, but it may be the majority of cases that get into hospital because they are the worst cases. When there is no resistance, the whole of the surface of the skin may be involved, and the bacteria get into the bloodstream, and there's a hematogenous spread, and no organ in the body is immune from the bacilli arriving there, but they don't develop the disease except in the superficial part of the body. Here's another case looked at from the back. You notice, which we'll come back to, that the central line of the back is relatively immune to lesions. You don't get many lesions crossing the middle line, and the middle line of the back is an area of relative immunity. Here's a long-standing case. Now he may be negative. He's had the disease for years. His eyebrows have totally gone, his eyelashes have gone. He has lagophthalmos with ectropion and inflammation of the eyes. He has partial facial paralysis. And this is the case of the long-standing leproma, who may by now have been so-called cured, but it's a very characteristic face. And here's a man, you notice this man has lost only the lateral part of his eyebrow, which again is quite common. And he is trying to close his eyes. He's been told to shut his eyes. And that's the best he can do to close his eyes. His eyelids, his eyeballs roll up, but he can't bring the eyelids together because he has paralysis of the zygomatic branch of the facial nerve, causing lagophthalmos. And he's in danger of blindness because his eye is probably also insensitive. Another feature of any kind of leprosy, particularly leproma in this case, is the claw hand. This is due to a paralysis of all the intrinsic muscles of the hand. You see how hollow the palm looks and how the thenar eminence, all these muscles, are totally paralyzed, and he can't bring the thumb forward in front of his hand. And here's a typical looking foot with ulceration, which of course is not, these are not ulcers of leprosy, these are ulcers of lack of sensation. We'll talk about that a little bit later on, but this is again a characteristic of the disease. And people go on walking on this foot without sparing it in any way, or even limping, not even the littlest bit, because the ulcers don't come into their consciousness. Here is a tuberculoid lesion. Now, tuberculoid leprosy occurs in patients who have some resistance. They're not leproma, they have some resistance, but not enough to prevent them becoming infected. But the infection remains in one place, or just in 2 or 3 places, and it's surrounded by a well-demarcated margin, and this area in here is totally insensitive. Totally insensitive. And the area just round about it is absolutely normal. And this is characteristic of the major tuberculoid. Between the tuberculoid and the leproma, there's a whole spectrum that's sometimes called borderline or dimorphous, in which you get features of leproma and some features perhaps of tuberculoid. This is the worst that leprosy can do, I think. This is called the Lucio phenomenon, and it's a form of reaction. It's a runaway leprosy. It occurs mainly in Mexico and in parts of Latin America. I haven't seen it. I think it occurs in India, perhaps, but it's so rare that I have never seen it in India. We have had a few cases in Carville here, either in Mexicans or sometimes in Caucasians. I have never known it to occur in a really dark-skinned person. People from black Africa usually get tuberculoid leprosy. They have more inbuilt resistance than the white races and the yellow races. But this is the Lucio phenomenon, in which you get occasional. This is a truly lepromatous ulceration. It doesn't occur in any ordinary form of leprosy. And here's our friend the armadillo, which, if ever we're going to have a vaccine, it'll be due to the self-sacrifice of the armadillo, the little Texas, Louisiana, Florida, 9-banded Dasypus novempicus, or whatever it's called, which is very susceptible to leprosy. Its body temperature is about 7 degrees Celsius lower than human body temperature, and it dies of leprosy. It has a massive infection of its liver, spleen, internal organs, lymphatic organs, brain, everything. And we can harvest very large amounts of bacteria from the... and of course 10%, I think I told you, 10% of these animals in the wild have leprosy. Now we come to my business, and that is the deformities. This is an absolutely typical case of probably one of the intermediate forms of leprosy. He may have been either a rather widespread tuberculoid or a borderline type of leprosy. He still has good eyebrows. He's not badly deformed by the disease, except that he has total loss of pain sensation in both his hands. He was working as a laborer in a construction firm when I saw him, and he was carrying bricks between the palms of his hand because he had no fingers left. They had gradually, one by one, been damaged and destroyed by a succession of wounds, and now he was carrying bricks between this palm of his hand with this ulcer and this palm with this ulcer. And one of those two ulcers, if you put a probe in, it showed the naked bones of his wrist. And if you waited probably 5 years, he would probably have lost one of his hands altogether at the wrist. This is the typical image of leprosy that people tend to have, the kind of person who doesn't think about what he does with his hands because he doesn't feel pain. Now, this is a diagram which I've put here in order to be able to say that this is not leprosy. A lot of textbooks, perhaps the textbook that you read, I don't know what textbook you read, but a lot of textbooks talk about leprosy causing a glove stocking anesthesia. And this is a diagram of glove stocking anesthesia. But I have to tell you that leprosy does not produce a true glove stocking anesthesia. It does cause more anesthesia, more loss of sensation in the peripheral parts of the limbs, but now this diagram might be true of an alcoholic neuritis, or it might be true of a toxic neuritis, but not of leprosy. Here is a typical lepromatous leprosy, and you see that the sole of the foot is still sensitive, but the dorsum of the foot has lost sensation. Here is a more advanced case of leprosy, and you see that the middle line of the back is normal sensation. The back of the hand is insensitive. The palm of the hand and the antecubital fossa and the perineum and the axilla all have normal sensation. I have never seen a patient with total anesthesia in the perineum. It's extremely rare to have it in the axilla, to have loss of sensation in the axilla. Now, anybody who knows anything about neuritis knows that there's no pattern of nerves which will give rise to that pattern of sensory loss. And here is a lepromatous patient who has lost sensation completely in his nose, both ears, and point of the chin, and over the malar cheekbones, a little bit up there, but who has normal sensation under the scalp.
I'm wondering about the physiological aspect of the skin of these patients.
Yes.
Do they show different resistance
Well, no.
conductivity of the skin?
No, I'll show this in just a moment. This is very puzzling, you see. If you try to relate it to anything that you know, it doesn't relate until you do this. And this is a heat photograph of my personal secretary, who doesn't have leprosy. And if anybody here wants to have a nice photograph of themselves like this, all you have to do is to get an infrared camera and take an infrared photograph. Infrared photographs heat patterns and heat emissions. And here is a normal person who has total, well, not total, there's nothing total here, but who has cold ears, cold nose, a cold point of the chin, warm lips, and this is almost a mirror image of your loss of sensation. And wherever the temperature is ordinarily cooler than body temperature, there you have damage to nerves. Wherever the temperature is kept at normal levels, like under a scalp covered with a thick head of hair, or inside the lips, you have no loss of sensation. Here is a very advanced case of leprosy, and the only remaining places in the whole body which are still sensitive is a thin line up the middle of the back and under a thick head of hair, and in the perineum, and actually you can see here in the axillae. So here's a person who's totally insensitive from head to foot, except for perineum, axilla, head of hair, and a little bit in the middle line of the back. Now, here is a photograph again of a lepromatous leprosy patient, and you see that for some reason the middle line of the back doesn't have any nodules, whereas the flanks have a very florid leprosy. Now if you take off your own shirt and have an infrared photograph of your back, of a normal back, that's what it looks like. A normal person, the flank is 1, 2, 3, probably 3 or 4 degrees Celsius cooler. The flanks are cooler than the middle line. The middle line of the back is always a warm part of the body, and it's the last place to get leprosy. The perineum is warm. The axilla is warm. The scalp is warm under a thick head of hair. And if you go and work in a country where people wear a very precise pattern of clothing, like for example in India, all the women in India wear, in my part of India, all wear saris. And the sari is a beautiful garment, and you have a piece of string around your waist, and the sari is folded into multiple folds in front of the belly, and these folds are turned over and tucked under the G-string around your waist, so that most of the body is covered with 1 or 2 layers of cloth, but the middle of your belly is covered with about 12 layers of cloth. And if one exposes the abdomen of a lepromatous woman, you'll find that she has an area of beautiful freedom of sensation and normality of skin in that area of the abdomen, where she always is covered with the sari, and all the rest may have. In Afghanistan, it's fascinating in Afghanistan, there in the high passes of Afghanistan, it's terribly cold in the winter. You go up to the Khyber Pass, or you go to down below that in Afghanistan, it's desperately cold. And the tribesmen up there use animal skins. They get I forget what animals they use, whether it's a lac or something like a sheep, but they have double skins, and they have one skin with the fur inside and one skin with the fur outside. So with this double layer of of skin they keep warm, and they are often stitched into their clothes for the winter. They'll cover their bodies with yak butter, and then they'll be stitched into their clothes with appropriate orifices for natural functions. And then that garment isn't taken off until the following spring. Well, that's an interesting way to live. But the interesting thing from the point of view of leprosy is that if you examine an Afghan lepromatous leprosy patient, you will see terrible lesions on his face, and often blindness. You'll see awful hands and awful feet. But you undo the stitches on this double furry skin and open it up, and you'll see skin as beautiful as a baby's skin under this, where it's been constantly covered by this warm double animal skin. So we learn then that the Mycobacterium leprae is sensitive to temperature, and that it does not like human body temperature. If leprosy is ever grown in culture, it will be grown at about 31 degrees Celsius, not at 37 degrees Celsius. And so if any of you want to take up cultivation of leprosy, you now know what temperature to use in your incubator. This incidentally that sentence was first used by a person called Brand, who wrote about this in India. Now, here's our tuberculoid lesion again. I won't go into that. In the tuberculoid, the skin, the patch of involved skin, causes an ascending affection of the nerve, the sensory nerve, causing gross sensory loss until it is joined by an unaffected motor nerve. And this motor nerve is supplying this muscle. And when the sensory lesion has gone up beyond that point of junction, then the muscle also becomes paralyzed. And then if it goes up beyond that to the next sensory nerve, then the patch of skin affected by that sensory nerve will also be insensitive, even though it may not have leprosy in the skin. This diagram is by Dehio, who drew it in the 1800s, soon after Hansen first demonstrated the Mycobacterium leprae. Here is a nerve, and you see, now that I've taken you through this area, you'll realize that the nerves are the things responsible for the stigma of leprosy. When a nerve is destroyed, all the other things follow. The paralysis follows, the insensitivity follows, the lack of pain follows, and when the lack of pain is there, people damage themselves and destroy themselves and burn themselves, and that's where you get the gross stigma, which remains after the bacteria have been eliminated. That this is the ulnar nerve here, showing it's rather thick as it approaches the epicondyle. And here is the sensory pattern of the hands, and I put this up to show that, basically speaking, there are two types of loss of sensation in leprosy. There's the initial loss, which is purely a skin phenomenon. The nerves that are in the skin, the sensory nerve endings, the pain nerve endings, and the subdermal plexus of nerves are damaged and destroyed by leprosy. But if the disease goes on, perhaps for lepromatous leprosy for 7, 8, 9 years, it's a slow process, then the disease goes up into the main trunk nerves. And this arm here, obviously, it has reached the ulnar nerve. And the ulnar nerve supplies these two fingers with sensation, and that is gone sensation from ulnar neuritis. And the median side is not yet totally gone, it's partly affected. And so, in addition to the loss by damage to the plexus in the skin, you may get a pattern of nerve loss which is associated with the nerve trunks. And this is more serious. And incidentally, let me tell you this, and this is a thing that's worth remembering if you're treating these patients. If a person has the kind of loss of sensation that I showed you at first, which is related to the temperature of the part, so that the warm areas retain sensation and the cool areas lose sensation, if that is their pattern, the treatment for it is to give them effective anti-leprosy treatment, because it is a direct effect of the Mycobacterium leprae. You don't need to give steroids or any other treatment. Just make sure they're taking their anti-leprosy treatment. If, on the other hand, you get this kind of pattern in which the ulnar nerve is affected, but not the median, this isn't a pattern of peripheral sensation, it's a pattern of the nerve loss at the trunk level, and those people will often come to you with pain. The first kind doesn't come with pain. It's a quiet, segmental demyelinization of the nerves, and the patients don't complain about it. You've got to look for it. But the patient who has neuritis in his ulnar nerve and median nerve higher up and so forth will be crying with pain, because there the cause of paralysis is not directly the Mycobacterium leprae, but is the swelling of a nerve inside its sheath. And that causes pressure in the nerve, and that causes pain at its upper end. So these people demand treatment. And if you get a patient suffering pain from a neuritis, which is segmental, follows the pattern of a nerve, then you don't give them anti-leprosy treatment. I mean, you do give them anti-leprosy treatment, but not for the nerve pain. You give them steroids or anti-inflammatory treatment, because this is a reaction of the body to the disease, and it's caused by an acute swelling of the nerve. And if you don't give steroids or some anti-inflammatory medication quickly, that nerve will be lost permanently. But if you can give it within a few weeks or a month of the onset of the pain, then you can often save the nerve and prevent the serious loss that would otherwise occur. So in the one case you give anti-leprosy treatment, in the other case you give anti-inflammatory treatment. But while you're giving the anti-inflammatory treatment, you still keep on with the leprosy treatment.
In Egypt, there is danger in the water. Each time skin touches water, there is risk of a serious disease. It's called by two names, either bilharzia or schistosomiasis. Bilharzia is one of the world's most serious causes of ill health. It affects 1 in 20 of all human beings. Attacking this disease is an Egyptian research team. The disease is not their only problem. Low pay and a massive brain drain to other oil-rich Arab states threaten their work. So, besides the disease, this film is about the work behind the scenes needed to keep the project going, and about the Egyptian way of developing and holding on to the scientists who are fighting bilharzia in the small town of Caillou. Cairo is where the director of the project lives, in a rather plain flat. He has always lived in Egypt and is deeply proud of being Egyptian. Dr. Mohammed El-Alami came to the Caillou project 20 years ago.
My interest in bilharzia came because this is a very important disease in Egypt. It is affecting a very big number of our population, of our working population, of people who are in their productive years, you see. So this is my interest. I want to have a role as a member in the team fighting against this disease.
He is a scientist with an international reputation and could have gone to work in the USA or Europe. His senior position in the Ministry of Health carries the privilege of a chauffeur-driven car. Every day he's driven the 15 miles to Kal-Yub along the banks of the Nile as it flows out from Cairo into the Delta. At the moment, his research group are testing a new German drug against bilharzia. It's been tested in hospital. Now his project is conducting the major clinical trial with the WHO. But his ambition stretches beyond the scientific goals. He wants to build a new generation of scientists to begin new projects and to take over at Kal-Yub when he retires. The raw material for that dream are the doctors at the Kal-Yub headquarters who are working on the drug trial.
فاطمة تعالي انت وزمايلك عشان نشوف شغل النهارده وايه اللي تم النهارده. يلا.
They are Dr. Fatma Aziz, Dr. Azar Fouad, Dr. Selwa Hasib Morgan, and Dr. Yusuf Adid. In Egypt, seniority commands obedience and respect. They must not smoke in his presence, nor cross their legs when sitting.
Okay. الأعداد الصغيرة طبعا عشان آخر البلد.
يعني يومين بالكتير قوي.
يومين بالكتير. اوكي يبقى نعمل شيفت بعدها على حلب. بإذن الله نكمل بقى 25% بإذن الله بتاعت
أنا مجهزاها يا فندم.
اوكي نشوفها
إن شاء الله.
اوكي.
His doctors are graduates from Cairo universities.
ما فيش هاتشنج في المجموعة.
And apart from Fatma, who was 1 month in the USA, they have not been out of Egypt. The work to be done in the trial is prodigious. The drug is being tried on 25,000 people living here in the Delta. They come to a village to set up a clinic. They examine each villager, record his medical condition, and give the new drug. A village will have 4,000 people, so they come daily for 12 weeks, or as long as it takes to find everyone. They did that here at Karan Field 3 months ago. Now they're back, finding the whole 4,000 again to see the response to the drug. The villagers don't cooperate out of idealism. What they get in exchange is free access to doctors.
ما رحتش بيها ليه؟
وهتشرفوا مصر
ما رحتش بيها ليه؟ بكلم ده. طب الصورة ماشي؟ يلا يا اخو.
Outside the village, the snail survey teams probe the water. The disease is carried by just 2 species of snail, so they measure how their numbers are changing. They sample the contamination in the water. Bilharzia is caused by parasites that come via a snail from another person. Inside the veins of a person with bilharzia live worms. Each worm is ½ an inch long, and they lay eggs. Myristidia can hatch from the egg. But that only happens if the person excretes into water. There are snails that Myristidia will attack. They seek them out and burrow into them. The snail produces cercariae. And it's these that are infective to man. They penetrate the skin and pass the disease on to someone else. The number of worms is measured by counting the eggs in the feces and the urine. So, to follow the effect of the drug, nurses collect the sample pots they handed out the day before. They'll have to process 150,000 samples before the trial is over, and that is done at their laboratory on the outskirts of Cairo. In the lab, the eggs are separated from the feces, and the whole life cycle is recreated artificially. The eggs are washed through a fine sieve, which holds most of the solid matter back. As soon as they hit warm water, the eggs will begin to hatch. Miracidia have about 12 hours to live, and they swim surprisingly quickly, attracted by the smell of a snail or, failing that, by the light. Each flask contains the feces of an individual patient, and the hatched Miracidia swim upwards to the light. Photogamil collects a Miracidium, and he places a guaranteed, uninfected, laboratory-reared snail at its mercy. The snail is left for 4 weeks. During that time, an amazing change takes place. Like an alien life form in a science fiction movie, the Miracidium has taken over the snail. It has made it into a factory churning out thousands of copies of itself. In the wild, the snail would continue production for maybe a year. In the lab, they grow the Cercarii to a worm and so complete the life cycle in a mouse. After 8 weeks, they wash the worms out, and so they have the worms of a particular villager of Karanfil. It's an Islamic religious requirement to wash yourself after defecation, so the eggs get into the canals because people use them as latrines. There can be hundreds of snails to a square meter, and each can release 1,000 Cercarii a day. It happens around midday, and the Cercarii rise, attracted towards the light. They're just beneath the surface in the afternoon, when most people use the water. Cercarii are attracted by the heat of a man's skin, and immediately they burrow in, taking as little as 4 minutes. Once into the bloodstream, they're carried to the liver, and there they live until they've grown into mature male or female worms. Then they find their mate. The female climbs into the male, where she'll live the rest of her life. It's a simple life. A mouth through which to draw blood, a sucker to clamp onto the vein wall, and 1,000,000 tiny spikes to move with. The male, with his female inside, crawls to the veins around the bladder and gut, and there each pair releases 1 egg every 6 minutes for up to 20 years. It's the eggs, not the worms, that do the damage. One of the first symptoms is usually blood in the urine, caused by the eggs bursting through the bladder wall. But the progress of the disease is not predictable. Some people live without symptoms. Others die within a year. For many, the eggs slowly destroy the liver or the kidney. 20 years of ill health leading to an early death. We wanted to know why the peasants didn't make any effort to protect themselves from the disease. We were told the peasants knew all about it, that they'd been taught about the snails and the Cercarii in school. The team from Kalyub, too, have been warning them of the danger in the water for years. This farmer was treated for it 3 months ago. Yet he and his brother took no precautions as they diverted the water to another of their fields.
بعد إصابتك بالهرسيا أنت عارف الخطورة بتاعت إن أنت تقف في المية والحاجات دي، عندك معلومات عنها، بتعمل إيه؟ بتضطر إن أنت تقف في المية ولا بتتصرف إزاي؟
بضطر إن أقف في المية وأشتغل فيها عشان ما فيش ليها شغل غير المية.
ضروري جدا إن أنت تستعمل المية وتقف فيها؟
طوالي بستعمل المية وأقف فيها طوالي يعني، وكل شغل هو في المية.
شعورك بيبقى إيه وأنت واقف في المية؟ بتبقى خايف من العدوى ولا ما بتخافش؟
لا ما بخافش عشان أنا فيها طوالي، خافش منه.
لما تتجوز ويبقى عندك أولاد وعيلة هتخليهم يمشوا في المية برضو ولا هتخاف عليهم؟
والله هو نصيبهم بقى، ان راحوا المدرسة اهو مش هينزلوا المية، ما راحوش المدرسة يبقوا فلاحين ينزلوا المية.
There is a tap for clean water in the village, but the women do their laundry and washing up in the canals. They said that in the canal, their soap lathered much better. They said they enjoyed the conversation. That at the canal, you didn't have to carry water at all. The suds moved off and the fresh water for rinsing moved to you. And that carrying their drinking water, which they did get from the tap, was burden enough. And with all the other work to be done at home and in the field, they were quite exhausted at the end of the day, without carrying more water about. We asked Alumni's doctors if there was anyone in the village who took precautions. We were taken to visit a woman whose husband had died a year ago of bilharzia. Because she is a widow with no relatives in the village, strict custom requires Zainab Aziz to live a separate life. She lives alone with her 5 children. For now, no man may help her in her field, nor in her house. Zainab said she will not have her children harmed by bilharzia. We asked her how she protected them. She works in her field growing vegetables and cotton, which gives her about £4 a week to live on. That means she has to work in the water. She knows if she becomes ill, there would be no one to look after the children. So to protect herself, she spends half her income on drugs, which she takes every 3 months and which she gives more often to the children. We said that she seemed to have remarkable strength. She said, I have to smile in front of the children so they don't think of their father. But what is in the heart is in the heart. Bilharzia has a very long history. In the pyramid of Lahun, there was a papyrus describing this disease from about 4,000 years ago. The symbol that the pharaohs had for it was a penis, passing what might be blood. They thought the illness entered the body through the penis, and they invented circumcision to protect themselves. Bilharzia began in Africa, but the slave trade carried it to the Caribbean and South America. So it became one of the most widespread diseases of the world. The first large-scale infection of Europeans came when Napoleon's army invaded Egypt. They developed symptoms quickly. Napoleon called it the land of menstruating men. When the British were in Egypt earlier this century, the old idea of infection via the penis was still believed. The regulation apparel issued for soldiers to wear while swimming was a condom. Scientific understanding of the disease had begun when the worm was first found by Bilharz in 1857. But it wasn't until 1909 that the Japanese proved that infection was through the skin. Cows whose legs were protected stayed healthy. Then the full life cycle was worked out. In recent times, the problem has got worse. A sad side effect of the huge dams that have spread across Africa from Kariba to Aswan. Attempts to control the disease began in 1927. In an isolated oasis, they tried to poison the snails with copper sulfate. But it took until 1947. Poisoning snails was tried in 1953 near Cairo, but the snails kept coming back from the surrounding area. In 1962, it was tried with an improved snail poison. It didn't work. The snails kept coming back. Then they tried to stop it by giving people drugs. That didn't work. The big success came in the Fayum Depression only 11 years ago. A single canal brings all the water to the area, and that was important. The Fayum is almost separate from the Nile. Its only connection is by the narrow ribbon of green where the canal crosses the desert. The canal was built by the pharaohs. In 1969, they began a two-pronged attack on both the egg and the snails. The attack on the snails took advantage of the special geography. They still carry on today, pouring poison by the ton into the water 6 times a year. It's expensive. They spend £500,000 annually on poison alone. It's a sophisticated chemical. It has to be lethal to snails, but harmless to man. As it's pumped into the water, it stuns the fish, which means a day's easy fishing for the locals. The pumping goes on all day. From here, the poison will be carried into the whole network. The Fayum is unique in Egypt in that the water flows fast enough to turn water wheels, fast enough to carry the poison through the whole system while it stays active. Reducing the number of snails was one arm of the strategy. The other was to treat people so they didn't put eggs into the water. The whole population, over 1 million, were tested for bilharzia. Almost half had eggs in their urine. Some of these people couldn't be persuaded to take the treatment, which was 12 very painful injections. Some were too ill to withstand the bad side effects of the drugs. A few people dropped dead at the end of the needle, but 80% of those excreting eggs were treated. This particular test has shown that a youth has bilharzia, but even the improved drugs used now are still dangerous. He has to have a medical to see if he's fit enough to take them. Controlling the eggs in the Fayum has not been cheap. The cost of the medicals, of the tests, of the drugs, of finding the people is high. Both measures, against the eggs as well as the snail, have been expensive. But expensive as it is, it works, and the water in the Fayum is safe. The same strategy is now being tried in the Beni Suef region. Again, one canal brings most of the water and one drain takes it away. But this strategy has not been applicable to the delta, the area where most of the Egyptians live. First, in the delta, there is not just one type of infection. The egg of the second type has a spike, and its effects are more serious. The water of the delta infects people with both types of parasite. The cure would mean having to return to the clinic 5 times to take the complete treatment, and the drugs have more serious side effects, so the cost would be much higher than in the Fayum. And the cost of poisoning the snails would be higher too. In the delta, the water moves slowly along weedy drains. There's no single point at which the poison could be put in. So, all in all, it has looked too expensive to control bilharzia in the delta. But the new drug Alamir's testing could change that assessment.
The importance of this new drug is that it is effective on both species of the disease. In other words, it affects the intestinal and the urinary together. And the second thing is as a public health worker, and I am treating people en masse. You see, I'm not treating people as single patients, but en masse. So, what I need is a good drug which can be easily administered and which is safe.
So far, the drug is proving safe. If that is the final result of the trial, it would mean that it wouldn't matter if it was given to someone who didn't have bilharzia. The need for the medical supervision and the tests would disappear. The hope for the future is that this drug, plus maybe a little snail poisoning just around the bigger villages, would make the water safe. And safe at a cost that Egypt and the third world countries can afford. Running this trial is not easy. In the third world, it's hard to find technicians who care about the accuracy of their work. Yet, Alumni is very dependent on his junior staff. For finding all the peasants and getting a sample from each takes a lot of personal effort and commitment.
معلش هو هيجي امتى؟ هو هنا بس بقول لك يعني كان مشرق شويه.
كان تعبان بقى، طب كان حلل عشان نشوفنا التعب بتاعه.
ونعمل قلنا له غلوبنا وياه.
لا يعني مش راضي. كانت فرصه ليه؟
يعني مش راضي.
عارفه كانت فرصه ليه وهو تعبان كده كنا حللنا له عشان نشوف اللي عنده ايه.
ما جاش كنت هتخلوهم هنديهم له تاني ما يجراش حاجه.
طيب ما هنديهم له تاني.
يلا
هنديهم له تاني.
وهنيجي بكره ناخدهم.
ايه هنيجي بكره ناخدهم وتلبيه عليه ان كان عنده تعب ولا حاجه هيبان في التحليل.
هنيجي بكره ناخدهم عشان يبقى صحته حلوه وكويس.
طبعا. بس ما تخلوش ينسى بقى. ها؟ يعني احنا هنجي لك بكره واخده بالك على اساس ان احنا ما نلاقيش العينات ناقصه بقى.
ويملى في البال الاخر هنا.
فهمتي؟ وتزود العينات عشان المرض اللي عنده يظهر.
Each page lists the people in one house and each person has a number.
88.
Those numbers have to stay with the samples they've collected and not get muddled. As the hundreds of samples go through the testing, there are many, many steps at which a mistake could be made. A number miscopied or results simply invented. One of the major problems Alumni faced was how to get the samples tested accurately. The urine is processed first. Pots are carefully lined up backwards. Number 19, number 18, number 17, number 16, and so on. So when the urine is transferred, the urine from pot number 19 goes into the tube marked 19. The most humble members of the team were careful to see that tomorrow's samples could not be contaminated or be attributed to the wrong person. Only an hour after they arrived, the samples were ready to be examined for the presence of eggs. At some of the other prestigious laboratories in Cairo, we were told research was severely hampered because many of their technicians hurried through their work and often invented results to finish quickly. In those labs, we were told they did so because they needed to be away by 12 o'clock to get to their second job. Technicians who work for the government are paid a small wage, about £30 a month, and many can't live on it. It's unofficially recognized that many need their second job, and a blind eye is turned when they go early. In any case, technicians in Egypt do not choose where they'll work. They are allocated to their job. So among technicians generally, there isn't a responsible attitude towards accuracy. The Kaloub research depended fundamentally on Alumni overcoming this problem.
I always get my technicians directly from school, and I give them in a good pre-service training. They don't come and work immediately, but they spend months and months till they come to the standard of work. You see, this is number one. Number two, I have a daily internal quality control. So, any of these technicians may be examining the same sample himself. He may be checking on another technician, and they are all checking each other without their knowledge. And it is only 2 people in all this lab who know the code. One technician, which is Sleen, and myself. Sleen!
Each day, Salim brings yesterday's results. If a person's work is accurate, they'll take home double pay. If not, they won't. He checks each person's score.
Very good.
So she gets double wages. He can pay the 100% bonus above the fixed government salary because he organized funding from the USA.
Excellent.
He made Kalyub a joint project with the American Center of Disease Control.
تزود عليهم ابتسام تقرأ قبال وفاء. ابتسام.
To hold his staff is a major problem. Egypt trains more technicians than the rest of the Arab world put together, but the Saudis and the Kuwaitis take them. They pay 10 times an Egyptian salary.
Okay.
How does Alamy deal with this?
I try as much as possible within my resources to cover this by increasing the pay and by building a kind of very strong human relationship between the whole staff. For example, I take care of their problems. Whenever any one of these people has a problem, he comes to me, he conveys to me his problem, and I take care of that.
Fodo Gamil is one of Alamy's senior technicians. He was trained in an army hospital during his 6 years military service, but then he went to Kuwait for 3 years. Now, with the money he saved while he was there, he's been able to pay the £10,000 key money for the kind of flat he wanted to have in Cairo. He had enough for furniture and to pay for a good education for his sons. The main reason he came back was that he's ambitious. He wanted to get a degree. He's now halfway through a 4-year part-time course at Cairo University. He studies 5 hours each night after helping with his son's homework.
أنا أحب أبي وأمي وأحب بلادي أدعو ربي كل صباح.
يعني أنا أحب أبي وأمي.
يعني أحب أبي وأمي.
يعني بحب ماما
وبابا.
وبحب بابا. وأحب بلادي. إيه يا بلادي دي؟
يعني الدنيا.
لا مش الدنيا، بلادي اللي مصر.
مصر. إيه كده.
When he came back from Kuwait, he needed to find a position with someone who would help him. He discussed it with Alamy.
I told him that I am coming here to continue my study. And of course he agreed.
This will satisfy his ambition being a university, obtaining a university degree. But he is going to continue with us on his technical work, and we will make benefit of that, of speaking English very well, and we'll send him after he finishes with the university to have more training in the United States. And I think by this way he has satisfied his ambition, and then we will get more benefit of him when he is now relaxed and free to do what he wants. Alhamdulillah. I always try to satisfy the people. You can't get the brain of anyone who is worried, you see. So let them relax, and then they will give you what you want.
The risk of his doctors going down the brain drain is acute. After graduation, they must remain in Egypt for a compulsory period of service. But after that, they'll be able to earn a fortune in the Gulf. Even with the boost Alamy gives the government wage, they only get £50 a month. And Yusuf, for example, can't manage on that. Yusuf lives in a scruffy development on the outskirts of a small town. His father died 6 years ago, and he has to support his sister and mother. He can't manage on £50 a month. He just manages on 150. He earns that and a little bit more from a private practice he runs in the afternoon. His work in the project is from 7:30 till 2:30. From 3 o'clock till 7, he goes to the small consulting room he's opened. It's in a village about 15 minutes bus ride away. He opened the practice with Alami's blessing. In fact, it was Alami's idea. He pushed the permission through the bureaucracy and saw to it that the application was approved by the local medical committees.
When I encourage my physicians to have their private practice, as a matter of fact, they gain more money, so they are satisfied. This is number one, and put this aside, because I will speak to this on this again. Number two, when he has his private practice, so he gets more experience, and he knows how to treat people, and this is reflected on his performance in the field. So I benefit from that, you see, and he benefits from that. Again, to return to the first point, when he gets more money and he is obligated to the patients whom he is serving, so he is more stuck to this earth, and he will hesitate to go or to be taken by the Saudis or the Kuwaitis or those people who have more money. This is my idea, and it has succeeded.
We knew that in Egypt, seniority commands obedience and respect. But we were deeply surprised at how much they have to place themselves and their careers in his hands. He is their patron. Only through him can they get promotion or a transfer to another part of the Egyptian health service. They expect him to look after their interests, and in return, they follow the career he designs for them.
Before he came to work for me, I told him, you are going to take the public health career. I don't have degrees in medicine. I will not send you to practice in medicine and surgery, ophthalmology, gynecology, or so on. You are going to study public health. So, my son, if you agree on that, let us begin. If you don't agree, there is no problem. You can return from where you came. Every one of them knows that. It is very clear.
He said that if I work with him in Alyub, he'll take care of me in every way. And he did. I think he really treats me like a father.
If I can say, it is a difference of culture. I looked at these guys as my brothers or sons or sisters or daughters and sisters. So I feel responsible for their career.
Once he told me that marriage will change all my career. That's why I didn't want to tell him. I had to tell him at last.
An Egyptian expects to be involved in much of the personal life of his staff. It was difficult for Selwa to marry against Alami's wishes. For years, she'd been trying to decide when to marry Wagi, a doctor now, but who used to be a student with her at medical school. She decided to marry, made the arrangements for her wedding, but she was too frightened to tell him.
He wasn't pleased at the beginning because it came as a shock to him. He wasn't expecting it soon, and I wasn't expecting it soon too. But now I think he's happy with my marriage. I think.
We, making this film, found it increasingly hard to reconcile Alami's ambition to develop them as inquisitive scientists, while at the same time expecting them to be rigidly obedient. That conflict was to become acute when we set out, simply so it seemed, to film their work in the village.
انا قعدت طول الفرح اشاور لك
تشاور لي ما انا عارف
باللي على شمالك لا
هي تشاورني وانا اشاورها هي تشاورني ايوه
لا كويسه كانت بنت ظريفه يعني
حلوه ها
بس هي عيب حاجه واحده نفس
When we asked them to show us where to go to film the farmers and the women in the water, we were amazed to find they had never been out beyond the clinic porch. Alami had said they shouldn't go out, so they didn't. But because he'd asked them to help us, of course they did. And they asked villagers if they would mind being filmed. It was Selwa who introduced us to Zainab. They came and translated for us why the women didn't use the tap water for laundry. And why the men said they had to work in the water.
I think it was a very good experience. I only used to watch people from the windows of the bus. When they come to our clinic, I just instruct them not to go to the water and to avoid it. But it is a major problem because they have to go because it's their work. I couldn't realize this without seeing them working and touching the water and washing their clothes in the water.
I felt that we have to try again and again and do a great job in order to teach them what's right and what's wrong, what's healthy and what's unhealthy. We have to try again and again.
I feel it's surprising that people who you are bringing on to be at the highest levels in 10, 15, 20 years, to be leading projects, should not have the curiosity to take themselves out.
I think you misunderstood the position. You see, they are working in public health research, you see, not public health service.
Yeah.
And there is a difference between both. If they are working public health service, they will go. But if they are working in public health research, the people will come to us.
In their research, the goal is to assess the drug. That does mean examining a very large number of patients very carefully. Their assessments must be done according to a strict set of instructions. It has to be that way so all their observations are standardized, so that their results can be compared with research in other countries. For example, it's tightly defined what is an enlarged liver and what isn't. We asked Selva, wouldn't she like to have more responsibility?
Dr. Alami likes to think that we share all the responsibility. I can't deny it. I would like to have more responsibilities, but I'm sure he will give us this responsibility when he thinks we're fit.
Selva is 28, a doctor, and has a postgraduate degree. Was Alami happy that she seemed to be so meek and afraid? Didn't he think they ought to be disobedient? Occasionally ought to tell him to go to hell, ought to take initiatives, if he wants them to be able to replace him.
I think you look to this scenery from a different angle than we are. This is our culture, Mr. Golden, you see. We are accustomed to look to our fathers and elderly and to our teachers with respect. And with not only with respect, with more than respect, you see. And these young ladies and gentlemen whom you have seen, either in the field or in the lab, they consider themselves as my students, number one. And they consider me as their teacher and their elder brother or father. That is why they behave this way. They can't behave another way, you know. They are not afraid. No, this is our culture, and this is the way, the normal way of behavior, you see. It is different. And you are measuring me with your measure. And if I go to London to measure some things, I may completely find it absolutely wrong, and you consider it normal.
In following our Western way of thinking, we had almost missed the point. Alumni is developing people to lead their own projects in the future, and he hopes, above all, they'll do this in Egypt. To do that means they will have to be able to overcome Egypt's particular problems from within the Egyptian culture. And that's what he's showing them. Alumni has created a research team whose data are accurate to the highest standards of the scientific world. His example, how he manages to make it all work in the Egyptian way, is the most fundamental training they'll need if they are to succeed in Egypt.
Very good.
30 years ago, Alumni chose to stay in Egypt. Why?
This is a challenge, and this is to prove yourself. It is easy to prove yourself outside your country. It is more difficult to prove yourself in your country, you see, and to challenge local circumstances. Because if I go to work for the WHO, in any place else in the world, I have the whole power of the WHO behind my back supporting me. But in Egypt, I have only our limited resources and myself and my people working with me, you see. So this is a real challenge, and the success of this challenge will return to my own people.